Meeting's being recorded. So great. Well, welcome everybody to our 55 minutes around the work that's contained in the book that was published last year, Solution Focused Practice and Mental Health Crisis, Inclusive Support Towards Safety and Hope. I'm really delighted to be able to welcome colleagues that have been part of that journey and that experience. Just wanted to start with a few thank yous. First of all, to Catty, who encouraged us to come, and Kata, who's helping us with the tech today. I'd like to say thank you to all the contributors to the book who aren't able to be here today, as well as the ones that are. I'd like to say thank you to Sarah Hughes, who's the Chief Executive of UK mental health charity Mind, who gave such a generous forward to the book. And I'd like to say thank you to all that have come to listen, those who have read or will read the book, those of you that will share it, and encourage the systems that you're part of to use it to advocate for change so that we can co-create more hope and more safety in environments of mental health crisis. So, to some brief introductions, my name's Nick Perry. My day job is as an approved mental health professional working for a local authority in the southeast of England. This is a statutory role, a key decision maker under the England and Wales Mental Health Act, independent from the medical model, tasked with making decisions about compulsory admission to psychiatric hospital, and focused on least restrictive alternatives. I did my solution focused training largely with Brief, and I've been an accredited member of the UK Association of Solution Focused Practice since 2023. We're going to present to you in the order the chapters appear in the book, and we're hoping to have a surprise guest appearance by Michelle Orr as well later in the presentation. So we have Alex Baku and Maria Long, part of the Assured and SASH studies and based at City St George's and North East London Foundation Trust. Raya Gul, very well known to many in the SF world, an occupational therapist by professional training and long-time higher education professional, author and trainer. And last but not least, Anya Garvey, solution focused coach, manager and speech and language therapist based in the Irish Health Service, currently finishing her PhD. Mental health nursing will be represented, we hope, by the hugely experienced Michelle Orr. And if I have time later in the presentation, I have a message for you from Natasha Adams, solution-focused youth worker extraordinaire. I suppose it falls to me to say a little bit about how the book has come to be and how it relates to us building hope and empowering change. Building hope and empowering change in all sorts of different ways. In the physical environments of mental health crisis, for people who are in distress, between colleagues who are working together from different training backgrounds under considerable pressure, for ourselves as we try to survive professional lives that are fraught with the perils of moral injury. Certainly this is the prevailing context if you work in mental health care in the UK. And it was very much the context for me personally as I refreshed my training in solution focused practice back in 2021, which incredibly is 5 years ago. Just as an aside, in our book, we speak of solution focused practice rather than solution focused brief therapy. This is because our range of professional contexts are broader than just delivering therapy. During the pandemic, when my Mental Health Act assessment work had increased exponentially, when I was amongst a small group of workers who weren't shielding and who continued to need to assess people in the community in mental health crisis, despite the physical health implications of coronavirus, when our options as AMPs to provide less restrictive alternatives and compulsory admission to hospital really started to fragment, and when I felt myself becoming more and more exhausted and pessimistic about my professional future, I realized that perhaps I had to start thinking of being an intervention myself. This meant deliberately choosing a new path, a training that could help me to have conversations that other people might find useful. Me as an AMP, trying to build hope and to empower change in each small professional interaction. And it started me thinking about the languages we speak in these environments of mental health crisis. Good people with good intentions, speaking different professional languages, expecting people at their lowest ebb to negotiate these differences and to be able to articulate their best hopes, rather than the history of the problem, without even being asked. This was the point that the idea of the book was born. As I was nearing the end of my training with Brief, and as I'd started to make anonymized notes of the impact that my solution-focused questions were having in Mental Health Act interviews, I began to dream about a mental health system that was staffed by people that could speak the same therapeutic language, who could work and hand over to each other, enabling the person in the middle of it all to feel understood, held, and supported towards safety and the hopes that they were articulating for them and their loved ones. My own chapter in the book shows how solution-focused practice can be used in the time alone with people in crisis that is recommended in our statutory guidance, the Code of Practice under the Mental Health Act, which will be amended over the course of the next year following new legislation that's passed through the UK Parliament over the last weeks and months. It shows how SFP can be an ally to anti-racist practice when structural racism remains a real problem in our post-colonial society and health system. My best hope is that this work that we've brought together in a small volume, small enough to fit into your work bag, might be part of a quiet revolution in mental health care, building hope and empowering change for individuals surviving against the odds, for workers who are tired and under-resourced, for systems that need new lenses for the work at hand, for organisations that are supporting experts by experience who can and should be involved in the provision of peer-led support, if only there was the funding and the infrastructure. Building hope and empowering change is about the personal, but it's also about the organisational. That's why we've reached out to senior leaders in health services and local authorities and political decision makers as we've launched this work. Whilst we know that other therapeutic modalities have good outcomes, we remain of the view that a common therapeutic language is helpful in physical environments of crisis care. Why not let that language be infused with SFP? So without further ado, over to Alex and Maria, who, amongst other things, will give you some feedback from the research and training they're undertaking with health professionals in accident and emergency departments within the NHS.
Hello everyone. We do have some brief slides to share, so I'm going to try this and see if that works. Yeah. There you go. Can you see my screen? Does that work okay? Perfect. Alrighty. So hi everyone, my name's Alexandra Baku. I am a postdoctoral researcher over at City University, and I'm here with Dr. Maria Long. Maria, would you like to introduce yourself?
Thanks, Alex. Hi, everyone. So I'm Maria Long. I work with Alex at the Centre for Mental Health at City St George's, and I manage one of the studies that we're going to talk about today. Thanks, Alex.
Awesome. So yeah, we're here today to talk about chapter 6 of this book, This Magical Light Bulb Went Off in My Head, and how training NHS staff in solution-focused practice can change the experience of people presenting in a mental health crisis. This was a chapter that was written with Professor Rose McCabe, who is the chief investigator in both of the studies that we're going to be talking about today, as well as Amina Akubat, who's one of the practitioners that participated in the study. So a little bit of a trigger warning, we will be talking today about self-harm and suicide, because that's what the studies that we work focus on. Yeah, so just to say, I mean, self-harm and suicide and the loss of life is a major catastrophic loss. It has a huge impact on people, on families, on children, carers. There's about 220,000 cases of self-harming that are seen in the emergency department every year. With self-harm, we're using the NICE definition. So that's defined as an intentional act of self-poisoning or self-injury, irrespective of the motivation. And a lot of the times when people present in the emergency department, per NICE guidelines, they receive what we call a psychosocial assessment. This is a time where a clinician will spend some time with the patient, with the client, to try and understand their needs. But very often in a very busy and very chaotic at times environment like the emergency department, this can very often turn into a bit of a checklist exercise. And very often there is no follow-up, and that can leave people alone in a time that they can be very, very vulnerable. So back when Assured was developed, this is a study, by the way, that is funded by the NIHR. There was some work done interviewing people with these experiences as well as practitioners and carers. And what was important is in these interactions was the element of human connection, understanding, and hope. And this is why we decided to design an intervention and use the solution-focused approach as part of this intervention. And so we're here to talk about this today. A similar study is developed for adolescents and young people. That's the SASH study. Maria, do you want to talk a little bit about that?
Yeah, so SASH is kind of the spin-off from Assured and focused on young people aged 12 to 18 that present to ED with self-harm. Young people get a bit more follow-up than adults do. It varies by area, but young people receive or should receive, as per the NICE guidelines, 1 7-day follow-up within a week of attending A&E. The issue is that young people are then waiting a long time to be seen by CAM services, child and adolescent mental health services. So SASH is really there to enhance the kind of therapeutic aspect of follow-up, because follow-up currently is very focused on risk assessment. And as Alex said, lots of young people don't find it useful and find that it feels more like a checklist than a kind of human connection. But also to provide a bit of a bridge while they might be waiting for further support. So the hope is that, so we designed an intervention up to 6 sessions. So there is a kind of problem-focused aspect where the young person is supported to identify their cycle of self-harm and how to break it and do some safety planning to help them manage future crises. But the majority of the intervention is solution-focused. So moving on to what the young person wants for their future, and then also involving carers, which we realize is really important. So involving working systemically and involving kind of the wider system around the young person. We also send on behalf of that practitioners, work with practitioners who we've trained who are CAMS crisis practitioners, to send the young people letters at 2 stages as part of the intervention. And we have a 6-month follow-up. The primary outcome, or the kind of result that we're trying to change, is self-harm, but we're also looking at broader outcomes like well-being, school attendance, and reattendance at the A&E. And both studies have kind of really incorporated the lived experience perspective. So on SASH, we've spent a lot of time consulting with young people who've used crisis services, and some parents as well, to kind of inform the intervention. Alex, I don't know if you want to say a bit more about Assured and the structure.
Yeah. So very similar to SASH. So we've designed the intervention working very closely with people with lived experiences, looking at delivering sessions over a period of 8 weeks. These involve the narrative interview and enhanced safety planning, and 3 sessions of the solution focus approach, which has been very, we're looking at some of the interviews that we've been collecting over the last few years, and it's been described as something very refreshing, both for clients as well as for practitioners as well. So the primary outcome is the ED reattendances with a referral to liaison psychiatry, and similar to SASH, we're also collecting lots of kind of broader outcomes around well-being. Just to say that very recently our study protocols were published. So if you want to hear a bit more about the research behind our studies, then these are the protocols. Yeah, and then we wanted to talk a little bit about how things worked with practitioners. So for Assured, we recruited several practitioners within the liaison teams, and they were all trained in the solution focus approach. We've received some very, very positive feedback. We've included some really interesting case studies in our chapter in the book, so you can really see how the solution focus approach was implemented in a crisis environment and working with people who are experiencing a crisis. I'm going to hand over to Maria now.
So this approach is, as we've kind of already outlined, quite different to what's offered in the NHS services at the moment. So some of the key kind of adaptations that we made were introducing more flexibility. So in the arrangement of sessions, so kind of meeting the adults and the young people where they were, if they were in crisis, and being more flexible if they did not attend, for example, and offering further sessions. And we also offered kind of bank sessions, which were so. In Assured, there was a standard structure of the 4 sessions, but then further sessions were offered that I think most people didn't take up, but were kind of there as a kind of psychological extra sessions they could dip into if the person kind of found themselves in crisis again. We also ran weekly peer supervision. So this was run by or supervised in most cases by Amina and Rose. So offering that kind of peer element where there was a lot of discussion about how the intervention fits within existing structures in the NHS, which was what we spent a lot of time kind of thinking about in terms of kind of the risk assessment focus and how to talk with other professionals in a solution-focused way. Just thinking about young people and working with other services around the young person, like social services, and making those onward referrals. There's a quote on this slide from one of our CAMS crisis practitioners that we trained in the approach. So in SASH, we trained over 45 CAMS crisis practitioners and some community CAMS practitioners as well, because in some areas they offer follow-up to young people. And so this practitioner talked about, so they say, at first I wasn't sure about doing it compared to what I'm usually doing, which is very problem focused, and the population are quite traumatized. I had reservations that it would be invalidating by not focusing on the negative and whether the young person would be okay with just focusing on where they want to be. But then I think over time with this young person, so they're reflecting on a particular young person they worked with, it's worked very well. Between the first and the second session, I was surprised by the shift that had occurred. And we saw those reservations come up in our training sessions and supervision. And it was really nice to see kind of practitioners reflect on kind of those initial reservations and how it can work with some people. And in our interviews that we're doing, we're kind of capturing more around where practitioners found that it did work and perhaps how we could kind of change or adapt for certain groups, for example, what we do. So in terms of how we embedded this, because this is a very different way of working, so we found that across the 2 studies, having practitioners kind of deliver this different approach was supported by having kind of senior clinicians in teams champion the approach, and that often that helped us then kind of earmark space for supervision. This was really tricky. Practitioners in these settings usually get supervision perhaps monthly, if at all. I think some practitioners very rarely got that space to really think about their practice. Offering top-up training. So we had our kind of initial training, which was 1.5 to kind of 3 days. We were flexible in terms of how many practitioners we were training. And then providing that in certain areas, elements of the intervention, also role plays. So it wasn't not much kind of talk content. It was very interactive. Kind of informal networks of support. So WhatsApp messaging between practitioners and some of the research team as well, when things did come up and practitioners wanted kind of more support. having that strong peer element of support, aligning kind of as far as we could, aligning the approach within the existing frameworks and processes in the teams that we were working with. And then also celebrating successes and sharing those testimonials and feedback between practitioners and also from kind of young people and adults and carers who were in the study to practitioners as well. So that was really useful. Alex, is there anything else you wanted to add here?
No, yeah, just to say that there was indeed a very nice community of practitioners kind of sharing what they've learned and how it was implemented in the service. And we are looking forward to the next stages of both of the projects now as we move towards looking at the final kind of qualitative and quantitative analysis. Yeah, it's been a very interesting process learning all about solution focused. So yeah, we're glad to be here today and share it with you. And that's us.
Thank you so much, both of you.
Thanks, Nick.
Amazing. I think it's a good point now for me just to add in the message that Natasha Adams has sent, because of course Alex and Maria and the team have been involved with working with young people, but there are a couple of other chapters in the book that are geared towards young people as well. Natasha's and also Luke Goldie McSorley, who many of you will know, who very experienced solution-focused practitioner and trainer, mainly working in edge of care services over the first part of his career for a local authority children's social services department, and now working in CAMS. But before I hand over to Raya, I'm just going to read to you Natasha's message, and she says her chapter, she hopes that it's shone a light on just how powerful solution-focused practice can be within the complex world of children and young people's mental health, particularly in her local area within Surrey Mindworks CAMS, where the NHS and voluntary sector work closely together. At the heart of her chapter is a simple but transformative belief that children, young people and their families should have real choice and voice in shaping their support, wherever and however they enter the system. One of the most encouraging examples Natasha shares in the chapter is a pilot triage for those who have been waiting a long time for help. By taking the stance that sometimes one conversation really can be enough, practitioners were able to help families co-create what would be most useful for them right now. The outcomes speak for themselves. 17% of children and young people didn't need a service at all once they'd had a chance to explore what was already working. Many with autism or ADHD chose local, place-based support rather than specialist pathways. If this way of working were scaled across all CAMS or Mindwork services, it could not only reach more children and young people earlier, but could also save the NHS an estimated £8 million per year. Through her work with Learning Space, Natasha has recently been commissioned to bring solution-focused practice directly into the NHS and voluntary sector through a new pilot training programme. This sits right at the heart of system transformation, supporting a right help, right time culture, building confidence across the workforce and ensuring families receive no more than they genuinely need. In parallel with today's presentation, this is why Natasha's not able to be with us, she's taking this work even further by presenting the chapter, the training and its insights to Surrey commissioners, helping to shape the future of what support would look like across her county. So that's her message, and the ongoing work from the chapter that she has written for us. So let me, without further ado, hand over to Raya, taking us more into work with adults.
Thank you so much, and thank you as well, Alex and Maria. That's really helped set the scene in a way for what I'm doing. So what I'm going to be talking about. For those of you who don't know me, I'm Raya Gould. I'm actually retired now. I was an occupational therapist, an academic, and a long-time solution-focused practitioner and trainer. And because I have a tendency to waffle, I've actually written out what I'm going to say. So forgive me if it isn't quite as fluent as the previous speakers. So I'm delighted to be able to present my chapter, which is called Service Users Are Doing It For Themselves. I wrote this with Mark Kilby, the former director of Take Off, which is a mental health charity, 100% service user-led in Kent. Take Off provide a wide range of service user groups, which and led by service users, which are either talking or doing based. And their guiding principle is that all their services are designed, developed, and delivered by service users. I'd been working with Mark and his colleagues when they were still a mental health service user forum, and had helped them to transition into an independent charity by providing a bridge to my then university's community engagement program. Take Off Kent is really unusual in that it has always been 100% service user led. My involvement has always been by invitation only, and this was very important to me as an occupational therapist. I had long been uncomfortable with the way that people with psychiatric diagnoses tended to be infantilized or overprotected by health professionals who only saw them as vulnerable and requiring constant monitoring and guidance. So I think you find that most organizations which are service user involvement and service user led almost always have a mental health professional sort of leading or so on. Take Off is quite unique in that it doesn't. My main input was that early on in the development of the charity, I was invited to train all the service users in solution-focused conversation, a simplified version of solution focus that I had developed to be used conversationally, and based on learning some common questions under headings such as, what are you already doing? What do you want to do? Turning negatives into positives, and finding strengths and resources. The training materials were limited to one A4 sheet of prompts, and the Take Off team have been using this as their primary way of talking to people since the start and until now. The training takes about half an hour. Yes, I did say that, half an hour. They get solution focus straight away, and they're really good at it. The most common comment that I got following trainings was, why don't all mental health professionals ask us these questions? Mark had invited me to run the solution-focused conversation trainings because my description of solution focus strongly resonated with him. He complained that professionals were only fascinated by how bad things were, but showed very little interest in how he'd got better. As he says, and I quote, they were hugely interested in, wow, you were in a coma for a few weeks. How terrible, and suicidal, and you've been locked up in psychiatric units for a few years of your life, and it must be terrible. Yes, it is. Okay. The real interest should be then, how have you rebuilt your life? How have you got back into mainstream society? Drive a car, get a job, get a girlfriend, have a house, and not ended up completely on the scrap heap. As Take Off became highly successful and respected as part of the local services, in 2016, Mark proposed to the mental health commissioners that they offer a peer-led crisis support group, which was eventually funded. Take Off are great at what they do, but they weren't evaluating their services in a systematic way. And I thought that it was particularly important that they should evaluate the crisis group as it was receiving funding from the mental health commissioners. So I donated my time to carry out a year-long qualitative research project to record the effectiveness of the group. So my chapter is therefore a record of that year and outlines how the research was carried out and the results. Data from the questionnaire was collected from all the attendees on a weekly basis, and then interviews were carried out with a sample of attendees and the crisis group leaders, who are also all, as I've said, they're all service users. Overall, the responses were positive, with 80% of attendances considered useful or very useful, and 99% of the time people felt at ease in the group. You can read the chapter for a breakdown of the responses, but one illustrative quote is, it can be a lifeline. It can be the difference between attending work for 5 days or having a complete breakdown. The responses to interviews clearly showed how solution focus had influenced these conversations. For example, moving a conversation towards exceptions. It was really important for me to see that actually mental distress is not necessarily something that has to be hidden, and that there are lots of people who can speak about it, and that there are people talking about living and working and not just about their difficulties. Another person reflected the both and aspect of solution focused when they said, "It's a shame professionals aren't asking me, how do you manage to be so resilient when you're also living with a mental illness? That would be a more interesting question. It would be nice to be given some credit for doing that." I have to just add at this point that none of these service users kind of knew that they were doing solution focus. It's some kind of special thing. They had just been living and doing what they'd been trained through this through the original training process. So I need to stress that people attending the crisis group are people with serious mental health problems and have to be referred there by a GP or other suitable mental health professional. The group, which is different to the regular way, because people can self-refer into any of the other groups, but for the crisis group, they actually have to be referred. The group takes place on a Sunday, late afternoon, which the team identified as a high-risk part of the week. For some people, it's clearly a lifeline. I'm so disabled when I'm unwell. I cannot do anything. I can't think, I can't read, I can't clean, I can't do anything. And to be able to do a small thing like a human interaction, for me, that's a really big achievement. We know that one of the benefits of being a solution-focused practitioner is to the practitioners themselves. This is also true for the crisis team leads I interviewed, who are all service users. And I'm going to finish with this last quote. "When you help someone by helping someone else with their problems, you're helping yourself. It doesn't make you feel better. It makes you feel like I've helped someone, I've made someone else's life better, and it spurs you on to try to help yourself. It's like you help someone else, you help yourself, you sort of get a bit of both." Thank you.
That's brilliant. Thank you so much, Raya, and leads beautifully onto Anya's chapter and the wellbeing implications for professionals.
Yeah, I think Raya, you've just summed up my what I'm going to say very nicely. I'm going to share my slides to keep me on track as well. Where are they? Share. And put that onto slideshow. So can people see that? It's been shared, yep.
Yeah.
Yeah, so I'm going to talk. Oh, I didn't put it onto slideshow there. I'll just put it there. Yeah, I'm going to talk a little bit about my chapter, which is based on the research that I am doing currently. Oops. So I'm looking at. Sorry, no, this is just put this down here. Sorry. So yeah, so I'm my research. I'm doing a doctorate at the minute, looking at the impact and the experiences of practitioners, and how working in a solution-focused way can, as Raya mentioned, can not only help the clients but also the practitioners themselves. Since I first learned about solution-focused practice over a decade ago, it transformed the way I worked, but also kind of transformed my personal life too. And it's something that I've heard over and over again at conferences, at trainings, or at events like this. So I wanted to kind of capture some of that. And I have been looking at the research on this, which there isn't a huge amount, but also I've been interviewing practitioners and getting their experiences of solution focused practice and how that transforms the way they work and their lives as well. So a bit of what's been mentioned already, Natasha in her chapter, and Alex and Maria mentioned too. By just working in this way, it's helped change work practice. People talked about things being more flexible and efficient. So people say, for example, I find out that people are already doing many of the things I might have previously recommended. And so wasting time on telling them things versus asking them what they're already doing was much more efficient. And the services ended up being more flexible for those people who were able to do that. People talked about how they listened, and that listening really changed the way they work and guided the way they worked with clients. And the idea of aligning to what the values and the way they wanted to work, being more client-centered. So people talked about the idea of working in partnership and how sort of learning about working in partnership in practice meant I'll be telling you what to do, and you'll agree. And it wasn't until I started using solution focused practice that I realized the partnership was asking people, and the solution focused way of working gave people that sort of the tools into how to do the partnering. And then that sort of impact that had on practitioners was seeing people more as humans. And so by so I'll actually just say what this person said. Yeah, you kind of pigeonhole people, and then you see them operating in this kind of space where solution focused questions are being asked, and people can really surprise you, and you can think, oh, I didn't think that person would think that or would want to do that. And it really helps you to see people much more in a rounded way. And I think, and that has helped with clients, families and colleagues. And people talked a lot about the sort of bringing the humanity back into their work, and how seeing people as humans, and how relatable people were, rather than maybe more othering than might have happened before. And there was a lot of talk about that idea of vicarious hope, and by listening to people and their hopefulness and the hope that came from the stories that they heard, even from people who were in really difficult, challenging situations, that had an impact on the practitioners themselves. And people talked about, there was a few people who had worked in a different way before and talked about, I would have left my job were it not for solution focused practice. And that kind of really helped in terms of their satisfaction, confidence and self-efficacy, and that talking about enthusiasm, energy and motivation. And there's some research we know about kind of lower burnout scores or increased vicarious resilience as a result of solution focused practice. And then there was a lot of talk about the idea of personal values and organizational values, and how this way of working supported that way, and that felt congruent with the way they wanted to work. And a key thing that sort of improved relationships, not only with clients, but actually with colleagues, and that idea of it spilling out into work with other people. And then people talked about their solution focused journeys, and that's been mentioned already as well. Sort of that idea of simple and not being easy, and when people have been really used to working in maybe more medical model type of setting and being brave enough to ask the best hopes, but by seeing the impact of asking solution focused questions and seeing how they worked, the impact that had on them, and that idea of how team meetings changed, and that's by asking small, implementing some of the solution focused questions and really listening to people's answers. People started to notice how less and less difficult or tricky clients ended up turning up, and that talking about people as if they were in the room changed, and people really noticed that kind of trust and belief really impacted on them. And that idea of, especially when people working on their own, maybe in a solution focused way, the solution focused community. And for example here, so what I would do is I would surround myself with people who were solution focused in lots of other places, and it was only I was the only solution focused worker, and I would say I would get supervision. So that idea of kind of getting the support from the community being really important. And then I suppose solution focused practice is not a panacea. It doesn't fix everything, although I think it's amazing. Working in organizations is not going to reduce staffing and organizational barriers that impact on that. But there was some really beautiful inspiration that people got from working in this way. So that's it.
That's brilliant. Thank you so much, Anya. So just aware of time, we've got 15 minutes or so, just under 15 minutes left of our time. I think it's a good place a good time to welcome our extra special guest, our favourite mental health nurse from Australia, Michelle Orr. And I suppose the link between vicarious resilience for workers is especially important when you're working at the sharp end of risk and trying to assess and manage suicide risk. So, Michelle, welcome.
So I'm chapter 12 in the book, and I think the title of the chapter is using solution-focused practice to assess and manage suicide risk. And the focus is really around acknowledging how laser-focused on hope solution-focused is when we're speaking with people who might be experiencing psychological distress, particularly to the point of having thoughts of wanting to die or take their own life. The chapter talks about the actual how the practitioner approaches the conversation, keeping, whilst it's respectful, the practitioner's own pace and tone actually helps keep that respectful approach going, not only just from an SF perspective, but just simply from their own how they hold themselves in the session, really. So we're listening out when we're just in any other solution-focused conversation, we're listening out for, well, particularly for these people, we're listening out for things that's keeping them on this side of life, in other words, their resources. And also listening out for reasons for living without actually asking them, so what are your reasons for living? Because that can be quite a hard question to ask someone whose choice in response to what they're experienced, their actual decision has been taking my own life is what would be the most helpful for them at the time. So actually asking something like reasons for living straight up would be really challenging. So that's the role of the practitioner, the solution-focused practitioner, seeing the people who've had these thoughts to actually be listening out for those reasons. And in the chapter, in the transcript that's enclosed in the chapter, embedded in the chapter, it talks about how that's the concept of reasons for living comes up towards the end of the conversation. The use of solution focus when we see people who have had thoughts of suicide or attempted suicide really gives the person their agency, make sure they maintain their agency and control over an outcome other than suicide. And the conversation that you'll see in the transcript is of a young woman where the conversation is full of her language. I've used no clinical language. There's actually not a scary clinical language in there at all, even though I was actually having a conversation with this woman in a crisis assessment team after she'd just been discharged from an intensive care unit following quite a large overdose. And so it's a lovely co-construction of a solution-focused conversation that's, yeah, like I said, full of her language. You get to hear about her resources that through the co-constructed conversation. And we not only hear about the history of the outcome that she's wanting, but also we move into the preferred future, and it's just so rich, full of hope and wonderful things that this woman has done and wants to do and plans to do. There's a paragraph there on safety planning, and we would normally have a really rich co-constructed conversation, as I said before, around the person's best hopes, their desired outcome, history, resources, history of the outcome, resources, and preferred future before we even head towards the concept of safety planning, because safety planning, I've quoted some research in there. We have to be careful around the solution focused is inherently a safety planning conversation. The hope and the reasons for living that are elicited from and the conversation around what the person is at the direction the person is wanting to go other than suicide is really rich in the conversation. So within that, embedded in that, is actual the concept of safety planning without even using the word risk or safety planning. And then if there is a requirement that a safety plan needs to be written, which in my organisation there is, that's something that isn't offered until the end of the conversation, because we want to make sure that there is a really vibrant and relevant, respectful conversation where clearly that person has agency and they can choose to complete a safety plan, a template, or they can actually, it sounds like X, Y, and Z has been really helpful for you, or whatever helpful word is there in their language. And that's enough to be documenting a safety plan for someone if someone chooses not to fill in an organisational template. So that's how we cover off safety planning. There's also evidence coming out that safety planning is actually, we have to be mindful of who the safety planning is for. Is it the organisation that they want that documented, or is it something that might be helpful for the person? Each person is different as to how safety planning works for them. It could be a photo as a wallpaper on their phone, or it might be a note that they have in their wallet, but notes are sort of probably less and less nowadays. Most people work off phones. It could be that they're knitting the next row of a jumper and they only leave that row half finished because they want to wake up and finish it the next morning. That's hopeful. We believe that the person's got to wake up the next morning. So that's basically it. There's the conversation. That's the transcript in there is really a really lovely example of the types of conversations we can have with people who have had thoughts of suicide or actually living beyond having attempted suicide. So thanks.
Thank you so much, Michelle. Okay, so we've got about 7 minutes left of our time. If anybody has any questions that they want to ask the panel, then feel free to raise your hand and we'll come to you, or if you prefer to put something in the chat, then you're more than welcome to do that. Anything that you'd like to ask, over to you. Your time to quiz this lot. Doesn't have to be a question, could be a thought or a reflection on what you've heard this morning. Just feel free to raise your hand. Maybe it's been so self-explanatory. Oh, Susan,
Yeah,
Please.
I think half an hour training, Raya, that's world record in brief. Can you say a little more about that? I heard you before, but it's always interesting. What was helpful? How could you do that?
Well, I think Anya and perhaps Alex and Maria. I can't remember who it was. I think actually it might have been Alex and Maria. We're talking about, people that initial overcoming of professionals have their reluctance to ask solution-focused questions. Having feelings you have to be brave to ask the questions. And I think Alex was talking about, there's this feeling like if you don't ask about the bad things, you're not honoring the person. The service users literally have none of that. They don't bring any of that with them. So there's no reluctance, there's no unlearning. They're simply presented with a set of questions which they try out. So the way we start it is literally just by saying, well, we're going to teach you this way of talking to people. There's some really useful questions. What we try and do is to shift people from the negative to the positive quite quickly, to focus on what people are doing rather than, what they're not doing, trying to make them feel a bit more hopeful when they leave than when they came in. So just using this kind of very ordinary language. And then the questions, and there are examples of them in my chapter. Plug that if you want more to know more about them, they're in the chapter. Then we put them into pairs. And we just send them away to have a conversation, and they just use the sheet. And there's just nothing. There's no barriers to asking these questions at all. So they just get on with it. And then because they know what it feels like to have the loss of agency or the loss of motivation or the feelings of inadequacy, all of the things that people are bringing with them. They understand that when they're working, they kind of have this fantastically intuitive sense of what to ask next and what's important to ask about. And they play with it they don't kind of stick to the script quite often. They play with it in different ways. And I remember a really important conversation I had with Mark when he came back and he said, oh, I had this incredible solution-focused conversation with someone today. And I was like, oh, yeah, what did you do? And he said, well, I had this woman, she came in to see me and she said, oh, I'm not doing anything. And he said, I don't believe you. And he said, and I got a piece of paper out and just said to her, right, tell me what you've done in the last week. And he just kept saying, what else, what else, what else, what else? And then he turned it round, gave it back to her and said, this is what mental illness does. It steals the truth of your reality away from you, and it lies to you. And this is the truth. And I just think, that is an extraordinary, and I heard so many stories like that. So I would say to you all, train your service users because they're so good at it, and they can teach us so much.
Brilliant question and a wonderful answer. Thank you. 3 minutes left. Anyone else want to put their hand up or put anything in the chat or to give us a reflection from their own work? Feel free. I think you've answered all the questions already, everyone.
It's just we just missed Susanne's little grandchild.
Oh, did I? I missed that. Oh, sorry. Good. Okay. Well, look, maybe it just falls to me to say thank you so much for coming and giving us the opportunity to share the work. We hope that it could be the beginning of a quiet revolution in the way that mental health services are delivered. For sure, if we have service users that are trained up asking questions to each other, we make ourselves redundant, which would be wonderful, wouldn't it? So, good. All right. Thanks, everybody. Appreciate your time, especially my appreciation to the presenters, my co-collaborators. Really loved working with you, and I think you've helped put something together which I think could be really useful going forward. Great.